can I just say to the audience, we're not here to redesign services or things. We're here really to listen and learn and see what's happening and get a feel for where the flow is going to help us. And that's the same with Alistair. Alistair's he's the lead postgraduate dean for oral surgery, and he's important in this training aspect, and also, you know, where these trainees are going to be placed. It has a resounding effect on the units, and we may have to think laterally if there's a drift in a different direction. So, Alistair, it'll be really interesting for your input.
Thank you very much, Mark, and thank you for the invitation. Let's just see. It's interesting listening to that about sort of service redesign, reconfiguration, everything else like that. Probably the best example I know of started probably over 20 years ago, and Professor Sandy, who's talking later, was probably responsible for it. It was about sorting out cleft lip and palate surgery organisation, getting it to raising the standards in the UK. So it's nothing new. It's been going on for a long time, and as he would tell you, it took an awful long time, but I think we're there now, and the results are something we can be proud of. I go off piece there, but here we are this morning. Where is oral surgery going? This is very much a personal view. I'm a general dental practitioner by background, so it's going to be simple. 25 years as general practitioner. I did luckily spend 10 years having my own operating list in minor oral surgery at my local district general hospital. So I have a little bit of a feel for how things are, but that, to be fair, was 20 years ago, so I'm not sure I understand how it is today. So hopefully, though, what I say will make some sense. What do you wish to know? It's always an interesting challenge for an audience. You might want to know, what are the drivers for change? I think Colette has highlighted a lot of those. What does HM's government want? I may talk briefly about those. What are the current service issues? Again, Colette has led in beautifully on that. But I think, as Colette alluded to, probably for you, the most important question is, what does the future hold for me with all these changes? And so hopefully I'll give you a view of how I see it going. And I think the future is very bright for you because you're very much needed, but it's making sure we make best use of your talents going forwards. I'm going to take a sort of strategic approach to it. I like to keep things simple, and strategy always says, where are we now, where do we want to get to, what's the gap, and what plans can we have in place to address it. So where are we now? Current graduates come out, and there's a lot of talk about how experienced or not experienced they are in a lot of procedures. But I think back, I graduated in 1977. I was good at busting teeth off when I graduated. I certainly wasn't good at using elevators. I certainly wasn't good at minor oral surgery. So have things really changed that much? Probably the only difference is I bust off more teeth by the time I graduated than current graduates. So there was a training need for me. Luckily, I had a couple of years working in hospital. My first day in Birmingham Dental Hospital. In those days, induction was very simple. In I went, they said, those are your 2 chairs, those are your 3 nurses, this was in locals. Can you manage 90 this morning? Shout if you get stuck. I was pleased, it was only 60 on the first morning. So new graduates, we have an issue about their experience, but I don't think that's changed a lot. Then, already alluded to, the 2006 dental contract, the root of all evil. It disincentivized practitioners who were happy taking out teeth and doing minor oral surgery to do it. You could still get your 3 UDAs if you referred. So if you didn't like taking teeth out, let's be honest, I love when they're out, but I don't like putting patients through it. So there was a natural incentive to dump, and that's what they did. So let's mention it. This is now the new body, the commissioning board. And hopefully the commissioning board can help us solve some of these problems by some good central thinking. Not telling us how to do it locally, but saying this is the direction of travel, this is the resource, now work out how best to do it in your area. But these are the standards we want it to be to. So there's a chance we can start to sort things out now with the commissioning board. Hopefully we can get away from the postcode lottery that patients have suffered for a long time. I don't know, can you read the text at the back of the room? Probably not. Okay. I got this mug from Workforce Development. Guess what? It's made in China. This may be your view of workforce planning, which is something that as a postgraduate dean I have to think about, that we'll do it and we'll come up with the wrong solutions. Thank goodness we can't outsource surgery to China or somewhere cheaper. It's too expensive to put them in a jumbo jet and fly them over there. That's one of our saving graces. Other areas, surgery, you've probably all seen the robotic surgery that's coming along. I wonder whether that's going to be able to operate in the mouth, because thank goodness the mouth is pretty awkward, and under local anaesthetic, Terry the tongue is the nightmare. I don't know how robots will compare. They probably won't get as frustrated as we do, but they might struggle. So where should we be? I've simplified this to the 4 R's. Right place. Right place from the patient, right place in terms of outcome. Ideally, patients, I think, would like their care delivered as near to home or place of work as possible. So that's a very important factor for them. Right time. How soon after the diagnosis has been made should the treatment be carried out? And I would have thought most patients want it as soon as is reasonably practical, and we need to be looking at that when we're redesigning. Right quality. The patient deserve the best outcome possible. So again, it may be about saying where can that be delivered. And finally, keep HM government happy. Out of interest, who in this room doesn't wish the government to spend your tax revenues wisely? The trouble is, we don't like it when they seem to be attacking our service or our salary, and that's one of the tensions. But the government is charged with trying to get best value for the taxpayer. They don't do it very well, but that's something they work on. I'd like to move on. These now, you've heard Colette talk about levels 1, 2, and 3. I'm trying to flesh them out now, but please accept these are literally Alistair's first doodlings on it. What may come out could well be very different. So level 1, as Colette said, basically this is something that we should expect every general practitioner to be able to deliver. Can you read it at the back? Or do you need me to read it out for you? Can you read it? No, you can't. Okay. So routine exodontia, elevation of roots, patients with stable medical conditions needing those, e.g. patients on warfarin, patients with mild anxiety, hopefully they should treat, fractured and sublux teeth, hopefully they can treat that. Exactly what goes into level 1, this can be determined as we're in discussion as to what is appropriate. Level 2, I would suggest surgical extractions involving bone removal with burrs. Stable but medically compromised patients, so perhaps a little bit more complex. Biopsies, patients with moderate anxiety requiring sedation, and avulsed teeth might be dealt with at level 2. Now, where level 2 is delivered, that is up for debate, and level 3 is coming on much more to what I feel is your area of expertise. Patients with complex medical conditions, maybe ASA 3 or greater, patients requiring GA, those with operative access issues, possible cancerous lesions, oral medicine cases, dentoalveolar trauma, TMJ cases, level 3. Most general practitioners shouldn't be going near those, needs to be referred in, and needs to be referred to the best people to deal with them. I'm sure there'll be a lot more detail going to the levels as they're developed and debate about it. Tried to give a guesstimate of what the percentage of these is out there in society. What do you think level 1 might be? %60% I'm hearing. Any advance on 60%? 85%? Yep, okay. I don't know, but my hunch is it is around 85%. This is just based on my experience as a general practitioner. Level 2? 10%? Yeah. We're on this, thinking along the same lines. So the mathematicians amongst you will work out we're on to 5%. Yeah, this is just finger in the air stuff. But you've got to start somewhere, because it also helps you do your workforce planning, looking at that, saying, well, how many do we need in each box to deliver it? So service reconfiguration. We've got an opportunity now to use contracting to drive that 40%, the appropriate bits, back into practice over time. We need probably to develop more services around level 2, whether those be in ordinary general practices where they have practitioners with the skills, whether they be in the salary dental service, whether in the long term, some people talk, some oral surgery will be delivered in specialist units on the high street. That's a possibility. I can't quite see Tesco's or Sainsbury's getting into having minor oral surgery units. I don't think it's a sort of practice building for them. So we'll need to determine what level do specialists operate at. Specialists in oral surgery. Are they level 2? Are they level 3? That needs to be determined. And then with hospital services, what can only and should be done in hospital units. And I would include in that enough work going through for training. As a postgraduate dean, that's critical to me in workforce planning, because if we don't train the next generation, we've got a problem further down the route. So it's critical when we're redesigning services to say, what's the volume we need to maintain that? Now, as long as you've got a small waiting list and you get the numbers coming through, it's fine. Do you need a big waiting list? Does it achieve anything? Working out what is appropriate to meet the needs for training for you as oral and maxillofacial trainees, and also for oral surgery, and maybe for dentists in practice. So I'm going to look briefly now at the southwest of England, which is the only area I have any real understanding of that, to put some numbers on it to give you a feel of it. 3,000 dentists, we've got 50 oral surgeons. I say single listing, this excludes your consultant colleagues who are both on the oral surgery list and the oral and maxillofacial specialist list. This is where it gets interesting. 22 are due to retire in the next decade, so we may have a service issue out there. We have 9 district general hospitals offering these services in South West. We have 33 consultants. We train 6 STRs in oral surgery a decade. So we've got a bit of a mismatch. 22 are going to retire, and we're going to train 6. And we train 16 STRs in oral and maxillofacial surgery. And we train about 50 SHOs. The new word for those is going to be dental core trainees, which is coming in, but I like to call them SHOs. I understand that still. So training and delivery. Undergraduate, they're doing the best they can with the resources they've got, so they probably can't make much change. We probably have an issue, and this is an issue for myself and my colleagues, about are we trying to make sure that the maximum amount of level 1 is done in practice and the dental foundation dentists get exposure to it. And that's something, a bit of research I want to do, is I want to look at my practices and see which ones are doing the most oral surgery and find out why. I have a hunch that it's practices where people had been resident SHOs are happy to do it in practice, and those that weren't aren't. And that may be another issue for us to look at in enhancing their skills in our recruitment of trainers going forwards. Dental core training, talk a little bit about that. I think it's essential. I personally think it's essential that they be attached to acute units, that they get involved in management of medically compromised patients, because it means you have a more experienced practitioner out working in the practice, so that the practices should be able, within the group of practitioners, to deliver the appropriate care. Dentists with enhanced skills. This is the new name for dentists with special interests, which the Department of Health is working with the Faculty of Dental Surgery on defining the competencies and the training for these people, recognising that we need to have more people out there who are probably not at specialist level, but are not at sort of graduate level in experience terms. And we will need to think about how we train them. Whether it's qualifications, personally, I'm not a great believer in qualifications per se, because they're great for testing knowledge. It's very difficult to say, has someone got the skill level? Now it replaces getting out there and getting your fingers wet. And it's about, for me, it's about saying, how can we generate opportunities for the people to get supervised training where they get good quality feedback, and then they can go out and practice it feeling supported. And this is where the managed clinical network with oral and maxillofacial surgeons at the top of it are going to be essential going forward to help shape these services. We'll need to look at what we're doing with the SAS grades. What training do they need? How many will we be needing in the units of the future? And the same with yourselves, looking at workforce numbers and saying, if we reconfigure oral and maxillofacial services, how many consultants will we actually need? no worries for all of you guys. I think there's going to be lots of work for you. I think we're looking at probably the cohort after you or the cohort after that, where we might be rethinking, do we need quite as many? So that we can guarantee if you do the training, there is somewhere for you to go. Coming back to workforce model in the Southwest, if we want to deliver at level 2, and we said 10% of the workload was at that level, I need to train 300 dentists in the Southwest. That's quite a challenge. It's going to take a fair while to sort this out. I can't see how we can solve that by saying oral surgery STRs is the solution. That's too expensive. We've got to up the game of our general practitioners and certainly, hopefully, encourage more people to go through SHO training where we can start to up their skills, and then hopefully link them in with a managed network where they can continue top-up training, be linked into their local units, and help deliver the service. And we're going to need to train more, as I say, at level 2. So in summary, it's obvious. Too little exodontia and MOS in practice. We've got to sort that out. We've got to sort out, well, the deans have got to sort out what's happening about our foundation dentists. Got to increase the number of GDPs doing it. I mentioned you're needed. Secondary care is needed. I think general anesthesia is the most fabulous thing for training in minor oral surgery because you can give direct feedback to the trainee on how they're doing, and I'd hate us to lose access to that. It's going to take time, but I think the new commissioning landscape we're getting into may actually allow us to put drivers in a lot faster to start sorting out at least that 40%, pushing most of that back, dealing with how we sort out level 2. That's a bit more of a challenge. 4 Rs should be there. You know what that symbol is? Chinese. Yin and yang. What are yin and yang? It's about seeing things different ways. Am I seeing it as black? Am I seeing it as white? Are these changes out there a threat or an opportunity for you? It's your choice. The Chinese believe that life is always about continuous change. In the West, we tend to have a philosophy about great stability and we don't want to be changed. Up to you. It's your choice. It's your career. You can embrace change or you can do a King Canute. Thank you very much.
Nice balanced move. Right. Are there any? We're running a little bit behind time, but do we have any questions? Alistair, if you're talking for the postgraduate deans in general, I mean, the message you're handing across is one of working together and trying to make this thing work as opposed to being difficult, disruptive, and breaking up the services. So, I mean, the theme is of working together. Is there anyone else? Anyone for questions? Yes?
Sorry, Gali from Oxford Deanery, one of the SPRs of the surgery. 2 experiences I've seen. When I was working with Prof. Shepherd in Cardiff, I was one of the specialty doctors, and we trained final year dental students to be competent in taking out wisdom teeth. They used to go for VT and come back a year after SHO, can't remember anything, because nothing has been done during VT to keep their skills up to date. And now there are a lot of problems with DF2s, especially in my hospital. We have decided that in August no more DF2s are going to be taking care of patients in the hospital environment anymore. So I can't see how we are going to train them if they are not going to get much in dental practice when they go out there. So how are you planning to do that?
This is, I think, back to the issues about how contracts are placed and monitored. That if you push it back, it's amazing how general practice will adapt if the incentives or the pressures are applied in the right way. But we've got to make sure the quality outcome's right. And I'm sorry, yes, I am aware of the issues that have happened in your unit and the relationship with the dental postgraduate dean, and it is a challenge sometimes. This is the challenge for commissioning, about making changes and making it sensible, and about can we all work together. And sadly, sometimes positions get adopted that aren't helpful.
Alenka?
Alistair, thanks for excellent presentation. Would you guys will be upset, or how far we can push the SHOs to training? I hear there's some concerns about SHOs cannot be trained ABCD further up, or they only had to do one or two things. Or do you have any restrictions on what we can train them?
Well, I think this is again, is we need to have a dialogue about what is appropriate training for dental SHOs, what are the outcomes we as postgraduate deans would want, being a little bit mindful of some of your service needs. Now, this is where I'll admit there are tensions and differences between the dental postgraduate deans on it. I take quite a different view that I believe all experience is usually good experience as long as it's safe. And that's the key issue, is to ask ourselves, is it safe? I mean, I do have concerns about one unit where the SHOs are being expected to consent patients for PEGs. I'm not sure that is appropriate, but these are some of the challenges as deans we have. I'd like us to work together on it and work slowly and try and evolve what is sensible. We perhaps, and I hope with the chairman of BAOMS, who's one of my associate postgraduate deans, we'll have the opportunity to have these sensible dialogues and work out how we can work together for the benefit of patients. That's the important thing.
Yes?
How long do you want your dentists working in SHOs to train for? Because currently they spend DF1, DF2, 2 years. And is that adequate? Is that going to affect the workforce if they're going to be longer to competent to work in primary care?
I'll be honest, I don't know, and this is something I think we've got to work out. Though equally, I think they are going to be more competent when they've finished their SHO years, if we can make sure they get maximum exposure to minor oral surgery and good supervision. They should be okay at that, and then they can go out into practice. Maybe that's where we need to link them back in, and we need to look at ways of continuing to enhance, dependent on local service need. But I don't know all the answers. All I know is we need to work together on this.
Nigel?
I'm just going to pick up on one sort of slightly throwaway line. I know this has nothing to do with recruitment. I totally agree with you about the concept of qualifications being purely a test of knowledge. But why have we got rid of referencing? If we're talking about people being good at skills and team players and everything, surely we're advocating bringing back a proper constructed reference into the recruitment process.
Which level are you thinking of there, Nigel?
At any level. If we're talking about clinical skills
Yeah.
being the mechanism, I mean, people have to have knowledge, of course they do. So exams are there, but they're not there as a hurdle, they're there to test the knowledge. But the skills testing can only be done in the workplace, and it has to be done surely by referencing. We can have some work-based assessments, but I mean, it's really referencing. They've all been thrown out the window.
Sadly, that seems to be the route that's gone down in medicine. I'm not sure, certainly in my own deanery, that we've gone down it in dentistry. I still like to see references at STR level. I know to get onto a performance list in the NHS, references are still taken up. But I take your point. I think it's about, we need valid evidence to be supported going forward. And equally, the valid, accurate data going into electronic portfolios, which that then might produce some evidence about at least the case mix, the volume of work that someone's done.
Awesome.
Thank you very much. That was an excellent presentation, and I think it's allayed some fears. I'm really reassured by your multiplicity of approaches to how to solve the problem, because I think the unspoken fear amongst our specialty was the answer was going to be a conveyor belt of producing more oral surgeons. And it seems like there's some imagination being put into this. But I think there is a problem currently, because we have a treasury of people who are experienced and currently working, doing exactly the type of stuff that we're talking about, in the guise of SAS grades who are already working in OMFS departments. And I think given the assurance that they could be recognised as specialists, they would go on and provide that service. They might look to do that in the primary sector, in addition to working in established units to keep their skills up. But there seems to be an active blockade to those people being able to get that specialist registration. And I think it's counterproductive. I don't know where it's coming from, but I have numerous people saying, can you help me? I want to get on the register. I can do it all, but I just can't get it.
Totally agree with you, and hopefully we can carry on chipping away at those things as we go forward.
Thank you.
Rob?
Mark, if I could just bring up to Colette's presentation. This is actually about setting standards for a service from a national clinical reference group, which sets the standards, which is about right person, right place, right time, etc., and measuring those outcomes. It's about competency, and it's how you grade that competency. So, and Austin's point is here, there are many people there who could fill that level there, and they can fill it very well for the cheapest price in the most appropriate setting, which will actually keep everybody happy. But it is actually, it will only come, in my experience now through trauma, is if you set your service specification and your outcome measures. If you don't set those, you don't know what you're going to have to teach and train to actually provide the workforce to deliver. And it's synergistic, as you've just said in the end.
Yeah. Makes complete sense to me. Yeah.
Thank you very much.